So this is a 38-year-old female with no known comorbids, presented to us with complaint of bleeding PI for 4 years. She is also giving history of altered bowel habits, but no significant history of weight loss or any other medication. Or to him. Yes. We'll be doing this course next week. Inshallah.
Thank you. Thank you very much. Make it sound like Elvis Presley. Thank you very much. Hello? She looks frightened.
Take it out.
It's okay. You didn't come out last night? You weren't there last night? You start away, my friend. Start away. Have you done the PR? Have you done a PR?
I did the PR.
Okay. Come on, friend. Just pop it here. Now we need some more gel. More gel. There we go. So it goes that way. There you go. Excellent, my friend. So tell me what you're doing, my friend. Just tell me what you're doing. Air. You're putting air in. Just, excellent. So, what do you need so you can see where to go? Well done. Nice and slow. Excellent. Nice and slow.
Hello.
Hello.
Before the break, the case that you did, the biopsies that you took, your provisional diagnosis on the findings were of proctitis, right?
Yes. Yep.
And you took 2 biopsies.
Yes.
What we saw
Yes.
was. Is that enough, or is it a specific number that you have to take from?
No. What it is that this person's already been
Biopsy
diagnosed,
proven, yes.
biopsy proving in the past. So all I was doing is that the colonoscopy they had in the previous, there was no mention of biopsies right further down the colon. All they said was proctitis. The proctitic area, it would have been negligent of me not to have took, just because I was doing somewhere from round the colon. I don't expect the ones from the right and left colon to show anything. They were just there as markers of reference. So in future we can say, yeah, we've had a couple of biopsies which showed no microscopic evidence of any inflammation in the past. So allow the scope to sit down, my friend. That's brilliant. So in the UK, I would normally, with someone with proctitis, take approximately 2 to 4 biopsies from the right colon, 2 to 4 in the left, and just a couple from the rectum. And that is enough then just to allow us to go ahead and treat the patient symptomatically.
Another question that
we-
I had
yeah.
regarding the last patient, we went on a break, so we couldn't ask. Was the colonoscopy indicated in that patient? She had already had a colonoscopy done. There was a sessile polyp, and it was biopsy proven chronic or colitis.
Right. The issue is that there was a mention of a polyp, if you remember, in the
Yeah.
build-up. So they had a sessile polyp in the
That was
sigmoid,
taken out.
which actually when we further investigate what the polyp showed, and it had an EMR to remove, actually showed evidence of just colitic tissue. So what they were questioning was there any further evidence of polyps further around the colon, such as DARMs or anything like that? So we were actually trying to rule out, was there any other evidence of? In true hindsight, I don't know how far the previous colonoscopy went, because I don't think that that was done at this hospital. Well done. Nice and steady. Excellent. Nice and steady. Now keep your hand slightly forward. You're allowing your hand to drift forward. Bring your hand back. That's good. I think the interesting thing comes with colitics is how often we should do the colonoscopy. Once we've got a baseline colonoscopy and it shows, for example, pancolitis, then we have an idea that because they've been symptomatic from this point, we actually then say that we treat their symptoms till we reach a certain point. 10 years? Some clinicians will say 10 years with others. Now, once we've actually got to that point, when do you do your next screening colonoscopy? Your next screening colonoscopy is based on the one that you have just done. So, for example, the first one, where you actually brought them back for their first screening colonoscopy after X number of years, shows pancolitis. You will do that, you will repeat it in 1 year. If that then in 1 year shows completely quiescent colitis, irrespective of further symptoms developing, be it bright red, fresh rectal bleeding, etc., you just treat the symptoms. You will repeat the screening colonoscopy in 5 years. Yeah? You got it? Yeah? Good man. No, get the tip central, use your wheel. That's it. Good man. Good man. Take your finger away from the air. Take your finger away from the air. The blue button. Take your finger, that's away from it. Good. Good. Here's where the hand needs to be. That's it. So anti-clockwise. Good. Keep it on. Keep the hand back here. Good. 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 Well done. Good. Excellent. Excellent. So that's it. Hold your hand here. Keep your view central. Pop that there. Turn this here. So it's here. Allow the torque to come in. There you go. No, keep it here. Allow the hand to sit here. There you go. Yeah? Advance. Have you got it? Have you got it? Good man. Keep the torque on. Big wheel up. So draw the big wheel back so the folds are there, so you've got to go, think of them as steps on a ladder or stairway. So the folds are there, follow the steps up. Good. Excellent. Where are we going? Slightly, no, don't do that. Why not? Right, put your hand there. What would happen if you push that down?
It will rotate.
It will cause this apex to move. She will get pain. Okay? So what you've got to do is work out when to do that. So we've got the scope. You advance the scope. Go on, you advance the scope. You've got it. Keep it on. Keep it on. Keep it on. Keep it going. Keep it going. Go on. More. Keep it on. More. More. Now, nose up. So tip up. So big wheel back. More. That big wheel further back. Big wheel further back. Is that, okay. Now, advance the scope. Advance. Keep going. Keep going. Keep going. Keep it. Keep the view in front. Keep the view in front. If you lose view, we have to come back. Okay, come back. Don't suck. On. Keep it up. Go on. Don't let go of the scope. If you let go of the scope, you'll lose the tension in the scope. Okay? Go on. Go on. Don't let go of the scope. You let go of the scope then. Go on. Now you can start to put this clockwise torque into the scope. Now you can put it back in. Go on. Now you can slowly put it back in. Advance. Put it back in. Now as you do it, put the clockwise torque in. Draw. Keep the tip central. So to keep it central, bring this round. Keep it on. So have you got the scope?
Yes.
Now you can start to do it. Draw it back. Big wheel forward. And now back. Okay. Now back. Now forward. Look at the lumen. That's it. Good. And now where's the lumen? 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. Have a look again. Bring the hand back. Okay. Where's the lumen? Yes. Good man. Now we know we've got a loop, not a problem. Patient's comfortable at the moment. Keep that torque on. It's very important. Okay? Come on. We can't reduce this till the tip of the scope is above the apex of the loop. Keep going. Keep going. Advance. A little bit of air. Just a little bit. Excellent. Keep advancing. You've got to keep the hold of the scope. Letting go of the scope relaxes any tension in the scope itself that we need to apply. So keep hold of the scope. There's where the lumen is. So big wheel back, nice and slowly. Yeah, brilliant. Too far back, so put it forward. So tip down, so nose down slowly. You've pulled the big wheel back too far. That's it. So now you know where to go. A little bit of air. Don't suck. You need to see where you're going. There we go. We're heading there. Keep going. A little bit of air. A little bit. That's it. Keep going.
Sir, can you hear me?
We can.
As I saw the scope, it has looped. So this loop
Well
is,
done.
as I saw the scope before, right now it has looped.
Yes.
This loop is in the transverse column?
No.
Where is it?
In the sigmoid.
Okay.
So when do you consider, if you're using scope guide, to reduce the loop? Would you do it now?
To reduce the loop? No, not now.
When?
When I reach the descending column, or when I
Well,
cross
if you
the
haven't got scope guide,
splenic
when?
fracture.
What the
When-
advice is when you've got scope guide, the tip of the scope needs to be above the apex of the loop. So if you have a look at the scope, you will see the actual the distal end of the scope, where the bending section is, which is now slightly discoloured, is above the apex. Okay? We've got a comfortable patient at the moment, so the protocol is advance till you get discomfort or pain, or it's unsafe to do so. We're comfortable, which implies that we're doing okay at this present moment in time, so continue. We haven't got any
Paul?
issues with regards tension. We haven't got any issues with regards potential risk to the patient. The issue that if that fails, once we reach a point where we need to reduce, we then slow the actual loop. Fails, we introduce scope, and then we withdraw with anti-clock. Fails, then consider our options. One is change of position, two is abdominal pressure, three is on the scope. Then we go back through the rhythm.
Paul, I just want to ask, should we fix the scope at that time in sigmoid?
Sorry, I couldn't hear
Should
you.
we fix the scope before going to
Fix the scope. You mean
yes.
make it stiff?
Yes, stiff,
No.
stiff.
No, I never make the scope stiff when I'm reducing any kind of loop.
Not in reducing. If we just pass the rectum and we want to avoid the loop in a sigmoid colon, should we
Okay.
stiff it?
What happens is, the reason why you get a loop forming an awful lot in the sigmoid is that people, pause for a second, she's just moving. You get a lot of people going in and they're going clockwise torque. I tend to reduce that, I go in anti-clockwise. If you notice earlier on when I just did the one with the gastroscope, I went in anti-clockwise, allowed it to come clockwise, drew the scope back and went straight. And that's how you keep a scope as straight as possible. The problem what you get is that because you keep going in a clockwise rotation, and at no point do you try to reduce that by going in an anti-clockwise fashion, you get this corkscrew effect. Don't worry about that. Are we comfortable?
Yes.
Keep going, my friend, at the moment. Excellent. Keep going. Keep going. What's up? Gel? Yeah. Well done. Okay, now, what you need to do, you hold the scope. Stand there. You hold the scope. Get your view so we can see where the view is. So it's there. Keep getting it. Right. Make sure the wheels see the view. It's too far back with that wheel. Leave that wheel locked. It is. Okay. Now keep that torque on. Keep it on. A little bit of air now. A little bit of air. A little bit of air. Big wheel back. Keep the torque on. Okay? You need to turn the scope so we can see the lumen. Big wheel forward. Forward. Right, now back slowly. More torque. Get that torque on. Turn that scope. That's it, more so. That's what's stopping you. So just bring this up to here. No, don't bend it. Bring it here. Rotate it here. Allow it to rotate. Allow it to rotate. Let me just show you, because at the moment, let go, you're okay. You've done brilliant. Let go. Don't worry, scope's going nowhere. At the moment, you've got the scope. Bring the scope round. Okay, so we've got it pointing somewhere. You see we're trapped under that fold? And then just draw it back. You can see where it wants to go. See the fold?
Yes.
So, yeah, so we'll just do that just for a second. And now when we get there, see it? I want you to pull that wheel back, right there. So you've got the big wheel back, okay? Hold that scope in that position with that wheel there. Your hand substitutes for my hand. Good. Hold that scope now. Look at the screen. Big wheel forward. Wheel back. Keep it coming, keep it coming, keep it coming. Step round. Step round, step round. Keep it coming, keep it coming. Step round. Big wheel forward. Step round. Keep it coming. Suck just a little bit. No. If that was real and you were doing that, that scope would have just dropped back. Okay? It didn't drop back because I had hold of it. Right? Keep it coming. Suck. Suck. Now, my friend, go forward. And that's how you reduce a loop. When to reduce a loop is often the biggest choice. When and where. Did you get that? Yeah? Did you understand what we were doing? What we were doing? Yeah? Excellent. Good. So, pause. What's causing your problem is this. Bring the hand to here. Now, where's the lumen? Don't do anything. Okay. That gave you the clue because you did do something. Right. Excellent. Let the scope neutralise itself and it'll take itself round. Go on. Go on. Let the scope neutralise itself. Big wheel back. And it'll take itself round. Big wheel back. Excellent. Big wheel back. Excellent. Clean your lens. Excellent. Advance your scope. Let the scope return to neutral. Don't push it. Watch and adjust your wheels so the lumen stays central. So as this comes down, no, don't do that. Let it return naturally. So adjust your wheels so it returns naturally. Okay? Adjust your wheels so it returns, that's it, so it returns naturally. And take the scope back. Now you're straight. Hand, there. Now. Good. Now you can go forward. Okay? Your hand. Oh, it's worrying me. When your finger's so close to that blow, I start thinking he's going to be putting it on. Excellent. That's it, big wheel back. Let the scope come round so you can see where it wants to go. See it? Now a little bit of air and clean your lens. Clean your don't suck. Clean your lens. Big wheel forward. Big wheel forward. Clean your lens. Now you can see what it wants to. Have you got the scope? Let go of the scope. Have a hold here. Here. Good man. So you can put on, you can take off. Big wheel forward. That's what it wants to be. Yeah? Big wheel back. Slow. Right, all yours. Excellent. Slowly do it. Slowly do it. Good man. Little bit of air, just a little bit. You sure okay? So far, how many times have I asked if the patient's okay? How many times have I asked if the patient is okay during this test? How many times?
Multiple times.
Multiple. That's a cop out. So, where's the lumen? Right, let me just show you. You have done absolutely brilliant. Just pop the scope down. Just let it go. People get very, very worried about letting the scope go. Right? The scope, for some reason, you're worried about it. Don't worry about it. Here is where the lumen is. Okay? Ignore. You like this. Right? Ignore it. What would you do if that wasn't there? Focus. Okay. See there? That's all it is. Go forward. The only reason why I've done this is because I could see her twitching her toes. And twitching her toes means, to me, too much air. Right. See the direction that is placed. Okay? You see the direction I've got that held. Don't let it off. You're letting it off. That's it. Good man. Can you scope like that?
Yeah, Paul.
Good man. Yes,
Paul,
sir.
Yeah,
Yes.
sorry. Did you say something?
No. I was handing the scope back to my friend and I said to him, can you scope like that? And he realised it was probably a practical incapability. Nice and steady. Keep your eye on that screen. Keep your eye on that screen. Keep your eye on that screen. Right, stop blowing. Keep your eye on that screen. Nice and steady. Keep your eye on that screen. Nice, gentle approach. Good man. Keep going. Keep your eye on that screen. I've got hold of that. You keep an eye on that screen. Advance. Go on. Advance. Now, why are you worried about advancing?
Because it is straight
It is.
transverse corona.
No, why are you worried about putting the scope in? You're very worried. Is it because you're feeling it resistance?
Yes.
More jelly. If you look at what we use here, right, you see this is lignocaine. Lignocaine gel, it dries out very, very quickly. So plenty on, and away you go. It'll take a second to take effect because we always put it on the scope outside the patient, and so we've still got that dry area. What I tend to do is take the scope back, lubricate, then go back in. But keep going now, nice and steady forward. And now it'll actually take an effect. How's that feel now?
It is easier.
It's easier?
Easier.
Okay. Nice and steady. Nice and steady. Well. Oh, Zia, my friend.
Oh, you boy.
You make a big effect, don't you?
Sorry.
How did the operation go?
You were so involved, I didn't disturb you at all.
I didn't notice you. Sorry, I apologise.
No, not at all.
Well, it shows you I watch what I'm doing. Right, so what are we doing about this tier 2?
Ah, you got that mail?
Yeah, I've got that, man.
I got the mail from the RCP that I am applying for a tier 2 and I should have applied from the GMC.
Yeah.
I got also an email from Deborah.
Yeah.
She is saying that I should have take a flap exam.
You should.
But the RCP, just 2 mails I got simultaneously.
Another one?
Another one. And they are saying I don't need to go take a flap.
You don't need to take a... No, you know you don't. You don't need to.
But then sorted out early as my last date to
You
apply,
send
17th
me...
October.
You send
I've
me...
just sent you.
Right. You send me that. I will send it to Steve because we're a little bit irritated with Deborah because she should be doing her job and she's not been doing her job.
Because at the last date, I
Can I request something, please? Zia, you're allowed to stay in that room, but you can't talk to Paul. You have to stay back and talk to him when he's done with this.
Okay.
Thank you.
There. Now,
Paul, sorry,
you're okay, my friend?
because I could see my friend Dilip not being very...
Stop. Right.
Now, we need to see that. Can we move that, white sheet? It's always, that's it. Can we move that white sheet a little
Stop
bit
what
more
you're
down?
doing. Stop. No, do not.
Yeah, इसको नीचे कर दो बेटा.
Okay. What I'm saying is, if you suddenly push that, you're going to cause this patient to have a lot of pain. Okay. So just stand there for a second. What I'm saying is that you're finding it difficult to go forward, right? This is causing difficulty. You would be tempted to grab this and do that. In doing that, you put a 180 of clockwise torque. This apex up here, which is now underneath the diaphragm at the splenic flexure, flattens down and goes this direction. So you then pulling down on the splenic flexure, which down on the splenocoic ligature, which could easily tear that away from the spleen.
Okay, sir.
So what we're going to do is take the scope, so we've got it here, bring the scope round, that is now neutral. You've got one loop here. Just for purposes of the test, then we can now steer the scope, and now we go anti-clockwise. The reason for going anti-clockwise is that will bring, as we reduce this, the apex of that loop forwards. Watch the apex. Now clockwise torque, slowly, and draw back. Anti-clockwise more, and draw back. Now can you see what that's done now to that? Anti-clockwise more, clockwise, big wheel back further, and now just draw back, suck. The scope now has got a little bit of clockwise torque on, anti-clockwise totally now to allow it to come back round. And now we don't worry about dropping ground. Now this loop that's here, we take back out, well I attempt to take back out. I'll do it in a second, because that hurt my ears on the actual thing. And then we go forward. And we'll
Taking it back out, can you do it slowly so everybody here can also see you?
Yeah.
Thank you.
So as we come here, you'll see it now. We've got the scope now in a straight line. So the scope is on a straight line, okay, practically. See the scope? Round. And how far are we round? It's very difficult to say. Bring it round, a bit more anti-clockwise. Now at this point, I would like to take it out, but I'm not. And pull back, put one in. This is because, again, I believe it's because we go in too much clockwise torque. Now we've got round here, now we can start to consider taking it out. We're at the hepatic. When we're at the hepatic, it's a clockwise torque that takes it down. Okay, you can see it where it wants to be. As I introduce the clockwise torque, I'm looking at the lumen. I'm not looking at the scope guide. A lot of people would at this point. Come back again. Scope now is starting to straighten. Come back again, suck. Scope is just feeling relaxed. Starts to feel more relaxed. Starts to feel more relaxed. And come back again a little bit more. So far we've now got a straight scope and we're pointing up towards the hepatic. We've not dropped back. And then go forward. Okay. She needs a bit more gel, but never mind. Gel, please. I now take the scope back, knowing that that will area will go back in easy enough. So as we go forward, this one, watch, comes round, ring back, keep the scope here, we're back to where we were, a bit further with the scope this time, drawing the scope back, okay, just drawing the scope back, keep it going, clockwise torque, draw back, suck. I tend to do this, which at this point, it's not something that we teach. I put the scope in a straight line. The straight line puts the clockwise torque in the scope. Okay? I pull the big wheel back. As I do that, I draw the scope back. The scope then goes forward. I take off the clockwise torque. I let the scope come down. I let the scope go clockwise. I let the scope come down. I let the scope go clockwise. I let it come back. I then look at where we are. Even though that was down into the cecal pole and it drops back. Did you see what I didn't do? Anybody want to comment on what I didn't do, even though I was dropping back? Around just once more for show. I didn't grab the scope and shove it back in. A lot of people grab the scope and then shove it back in. Is she okay? What about now? Is that better? Now we need to wash this area because we are round. Wash, my friend, yeah. Thank you. So you're round. We need to wash the area, okay? Even though we've got this appearance here, I don't worry about it. You wouldn't know about that if you hadn't got scope guide. The other thing is we're at 65 centimetres. So 65 centimetres and we've still got what appears to be a loop at the splenic flexure, but it'll be a small one all the same. Can you see what I'm suspecting? So looks a little bit angry in places, doesn't it? My friend? Yeah? Keep going. Keep going. Oh. Is the water there? That's blowing air, my friend, because I know it's blowing air because it's blowing me away from the cecum. So did you notice how just a little bit of air from that machine was blowing us away from the cecum? Have you got syringes if that doesn't work, my friend? Nah, I'll have syringes, my friend. That stopped again. Thank you. So what you've got to do is decide very quickly what is the right thing. The right thing is that device is okay, but it keeps breaking and detaching, so it's shooting air into the colon and causing me a little bit of instability. I've got my finger on the blow, I'm sucking intermittent. I've got my finger on the blow, I'm sucking intermittent. Finger on the blow, sucking intermittent. Finger on the blow, sucking intermittent. Finger on the blow, sucking intermittent. Have we got some water, right? Wait. Water? An injection? No, not yet, my friend. Now, did you see why we lost ground then? I looked over my shoulder for Eric.
What?
Not yet, my friend. Now, boss, where are you? Water, please. And more, my friend. So the history of this lady suggests what? The history of this lady suggests
Bleeding, pain, medication.
we just got a change in bowel habit, we've got no blood.
Bowel habits, filtered bowel habits. And maybe tuberculosis. Weight loss is not significant.
So we're there. See where we got the lumen? Have we got some more water, my friend?
You'll get full marks for cleaning, Paul.
Sorry, my friend?
I said you get full marks for cleaning.
Cleaning. Well, I thought there was a little bit of blood somewhere, so that's what I was worried about. But if you notice, we've got no loops now of any description. Appendix is there. Just going to turn in. And come back. And again, just turn in. So it's probably just a little bit of debris. There we go. Right, so what's the history again, did you say?
Abdominal pain.
Abdominal pain.
Bowel habits and bleeding.
Bleeding PR for 4 years.
Paul,
Yes, sir.
do we
Please,
have
yeah.
NBI on this scope? I'm sure we do. Do we have NBI?
Enhancement.
Can we just show some of the things, because some of the candidates have not
Right.
obviously seen this new gadgets.
Right, image. No. There, that's a better image. So there's your MBI image. Can you see the little cells just there? So we've got the little prominences in the terminal ileum.
Yep.
That to me is all normal. So we have a look across here. Keep going, my friend. And again, all normal. Can you see they're all concentric? They're all similar.
Yes,
There's
clearly.
no change. There's no little. The MBI picks up blood flow. That's the most important thing. The other thing is in the UK, this can sometimes look red in the presence of stool that has had the type of bowel prep we use, because of the high salt content in the actual bowel prep. And under MBI, the salt changes the colour to red. So we actually think it actually looks quite bloody, whereas the bowel prep you use doesn't show that at all. So as we come back again, this is normal vision now. Come back just once more. MBI again, my friend. So we can see everything there is looking okay.
In your practice, when do you use NBI, Paul? If
I
at all?
use it just to, I mean, to be honest, because there is a drive under bowel cancer screening that I have to talk about Kudo and bloody Paris classification, that's the only time I ever use it. I'm actually quite disenfranchised and unhappy with MBI. I don't use it very often at all. I don't think it tells me a great deal. I think it is a toy. I think it is a gizmo. And I think it's well had its day. I'm sorry.
Can we see the high definition or enhanced view?
So that's on 5. That'll probably be the highest you do.
Oh, look at those real eyes now.
Can you see them?
Yep.
So everything there is uniform. Not a problem. I'd be very happy with that.
Now.
Are we happy?
Yep, we are very happy. Thank you.
No more. There you go, my friend. So if you notice what I did was that I froze the image. So when you want to examine something, freeze the image. The scope can do all sorts of various things, but freeze the then you can actually focus on what's in front of you. That is the best bit of advice I can give somebody when it comes to doing anything in colonoscopy or endoscopy of any description. So a lot of times things are moving. We've got other things that are interfering with it. Keep your finger away from the blow. And so freeze the image and then see what you've got in front of you. See? Clean your lens, good man. What do you think it is? Is it a polyp?
No, bubble.
Bubble? Are you 100%? See, it's amazing how you can put doubt in someone's mind even though it is a bubble.
Yes.
But if I say, is it? You'll say, oh, it must be something. So best thing to do, because we've got a little bit of doubt, just because I put it there on purpose, because I'm a bit like that. Do that. You were right. It's the devil in me. Yeah? Keep the torque on. See the torque? You can't just pull it back in a straight line because things are coming round and they're going to do this. You need to steer it round the corner. So what are you doing? Ding. Can we switch this thing off somehow? Because he's focusing on this big style. There. Now see it. Thank you.
Is one of the junior doctors there, Paul?
I'm afraid not. We've got one of our...
It's okay, I've got them. Thanks.
Okay. Hey. They'll call me Paul by the end of tomorrow. I know. Good. Right. What have we got left, Eric? What's left?
Yep.
Yeah, colon-wise. This it?
Yes. Finish. Last.
Clean your lens.
Then from
Good. Very quiet, isn't he? He's very quiet.
आप ज़्यादा बात नहीं करते ऐसा कहना बिल्कुल खामोश नहीं
What's he say? I've got nothing to say.
क्या बोलते हैं आदत
Dilip is a quiet person, man
He's
of
a
few
quiet
words,
person. Shall
man
I-
of few words,
I'll
but
ask his wife.
you can ask anybody's wife and the answer would be the same.
What, that is a man of few words? Suck.
No, that he doesn't stop talking at home. That's what I hear all the time at home, and I know you do.
Oh, I'm very quiet in the presence of my wife. I have no
Yeah,
option.
we've seen that.
Yeah, I have
We're witness to that.
absolutely no option. Have you met my wife? She's the little dumpy one that's in the... You ask my wife how I describe her. She went on a course once and they say, tell me how your husband would describe you. So she is. So Janet will now tell Saad what she said to this, who were absolutely shocked. Has she told you yet, Saad?
Short, fat, and hairy.
Right. First of all, before anybody does a J, what should we do? Tell her. Because doing a J is more of a surprise and you coming up behind her and not telling her you're going to stick your finger up the bottom. Doing a J is, whoa, business. So let her know what you're going to do before you do it. So you're just going to give her a bit, you know, whatever.
Paul, we have got some observers sitting here and obviously some candidates as well.
Yes?
So as we come out, it'd be nice to see how you retrovert or you teach
Okay. So-
Dilip how to retrovert.
Okay. Now, what I'm going to ask him to do, the scope is now at 10 centimeters. If we look at the lumen, we can see that the main part of the lumen is up at the top now at 12 o'clock. I'm going to ask him to draw the big wheel back, all the way back slowly, slowly, all the way back. Now I'm going to ask him to pull the little wheel all the way back, slowly. Now he's done that, the scope is in. I'm going to ask him to advance the scope, hold the scope, that's it, break the two wheels. And now advance it, and now do a bit of clockwise torque, anti-clockwise now, anti-clockwise. And as he goes in, and then back to the neutral, he will then see where the lumen... there you
I
go.
don't, but you
Clean
can.
your lens, don't suck. Don't suck. And there you
Oh,
go.
look at that.
And the reason for the little wheel back, it will be shown here. Advance the scope a centimetre. Keep that torque on. No, keep that torque on. Advance the scope. Have you got it?
Yes.
Let go of the little wheel. That's the little wheel into a neutral position now. You cannot see what we've just seen.
Now we'll demonstrate that here as well. Once the scope is out, it's even better seen, right?
Yeah, so there
So-
it is.
So
Little
just
wheel
watch
back.
the screen, Dr. Dilip, so we
Clean
can.
your lens. Yeah.
Okay, there's something juicy there.
And then you can see off to the side. Can you see it? As you go round, so you can see off to
It's
the side.
important to do a.
If it's too sharp, then this is where you actually release the big wheel a little bit. Just to release the big wheel, just a little fraction. That enables you then to see the scope. Yeah? Okay, my friend? Now.
Okay,
hold,
Paul.
Hold the scope.
Do you normally lock your wheels when
No,
you're doing
never
it?
lock the wheels.
Never lock the wheels.
Yeah, I'm sorry I sounded a bit passionate there, but never lock the wheels. These wheels are not locked. Never lock your wheels. To unjay,
Why don't you lock the wheels when you're just doing it and then unlock? That's the question.
I don't do it because I think it's barbaric, because the scope then becomes fixed. Because when the scope is rotating, my thumb can feel a little bit of pressure
stiffness.
onto it,
Yeah.
and then I can relieve that pressure on the wheel accordingly. Because when you're doing a J, there's a lot of pressure from the rectal mucosa, and when you pull it down, you do need to feel that pressure. So if you've got the wheels fixed, you will just traumatize the mucosa. It's going nowhere.
Especially when you sometimes have difficult cases.
Yeah.
It's
Unjust
very
them.
important.
Don't force them. Don't
Understood
force
what
them.
he said?
Just allow them to relax, and as they relax, just take the scope out. Allow them to relax and take the scope out. That's it, just allow. The wheels will move themselves. The wheels will move, see? Will move themselves. And out. That's it. So, this is the scope. I get it back to the scope sitting about this far into the anal canal. So we've got just this proximal tar about 2.5 centimetres in the anus. Point it where it's needed to be. Big wheel back. Have you noticed? Pull the big wheel back. Now reach round, little wheel back. All done with one hand. That's with the little wheel back, and that's it kicking off to one side. Without the little wheel, that's where it sits, and that's what it views. Okay?
Paul,
Yes, sir.
it's a natural thing where you start using the big wheel, and kind of halfway the small wheel comes and says, hello, take
Yep.
me
So what I
along
do,
with you.
If you look at the D,
Yeah.
I pull back,
Yeah.
one wheel comes down, second wheel comes across, and then it's there.
See, and you almost always use both, right?
I always use both, and I always say if the little wheel comes back, then I go anti-clockwise.
Yep.
Can you see it? Because it's kicking off to this side. You can pull all the way back, and if you want to, then do this. But I find what you need to do is understand that if you do that, the scope will move. And
Yeah.
again, and then this time,
Yeah.
yeah,
Okay.
I always do it this way.
Understood the difference between big wheel and small wheel and together and single? That's totally.
Pulls it back, that little bit.
I mean,
And then the most important thing is, on this one, the little wheel comes back a little bit. Because I've got it here now, if I had a little bit of pressure, so it's pulling here, you can see the wheels themselves, they want to move. When I actually take it out of the anus, if it comes back, I push the wheels so they're neutral, not completely neutral, leave them relaxed, and then then it comes out. I allow it to steer out. I don't force it out. So doing the J, big wheel back, little wheel kicked over, grab again, and that's it. One hand. There's a lot of people who would say, big wheel back, hold it with this finger, pull this back. I think it's garbage. So I just pull the D down, the next one below the U, thumb comes across, both down, then across, and then done. Takes a little bit of practice, but once you've done it, it's easy. Excellent. You okay, Aaron?
Yes.
A little bit of clockwise. Excellent. Much better. Sorry. Yours just go like I do. Okay. No, that's actually the coming back into the proximal sigmoid. Yes. So a lot of the time, what sets you up wrong here, a lot of people, okay, will go clockwise. I want you to look at this area here, okay? Just think, keep hold of that scope exactly where it is. No, right there. I'm going to put that scope there. Try this, okay? Adjust your wheels so it comes anti-clockwise. Go on, you do it. So it comes anti-clockwise. Now draw the scope back. Now adjust it so it goes anti-clockwise. Okay? Now let it go round. You cannot touch that with that hand. You've got to keep hold of this. You won't have me with you. Okay, let it go there. And now, there you go. And let the torque come in naturally. Big wheel back. Okay. No, don't force it down. Let me just show you, because this is the bit, and then you can do it. I'll take it back. All right? So we come back. So we're here. So as you come in, okay, it forces it up. You see where it wants to go. I step back.
Yes.
I allow the scope to come round. See it? So the scope comes round.
Yes.
Big wheel back, so it comes here. Now let the scope neutralise. The reason for that is that once it sees the lumen now, once it neutralises, see the scope neutralises, and take back, the scope will go straight. You see, sir?
Yes.
So again, come in, so we can see what it wants to be. See here? So that's actually pointed at him. So that. So it, watch it there. So it comes up. See the 60? Yeah. That's it. So come up. Good. Follow it round now. So bring that up. Just slowly to there. Good. Just to there. Keep it close to you. Elbow down. That's good. So you've got to keep it close to you, but you've also got to keep it close to the lumen, because it comes round, it sweeps round. Right, that's better. Go on. Go on. Go on. Brilliant. Excellent. All the way up now, so big wheel back. So big wheel back. Excellent. Lovely. More. Great. Clockwise torque. Draw back. Anti-clockwise.
This was the spinning.
No, this is still. You're itching for that splenic. Draw back clockwise. Keep on the torque. Anti-clockwise. Clockwise. Anti-clockwise. Clockwise. Suck. 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 Clockwise. And now, nearly straight, go forward. Keep that torque on. Do not take that torque off and go forward. That's good. But even doing that changes the torque. This is the torque. I don't want it on, off. Okay? Good. Keep going. Nice and steady. Keep going. Nice and steady. Keep going. Pause. Why have we got you to pause? Why did we get you to pause?
Because to turn the patient in a
No, he actually moved his right hand, okay? I was looking at the screen with you, but he moved his right hand.
yes, I think they are saying he is mentally retarded, so we don't know the.
Ooh.
Yes.
I never ignore it. So he moved his right hand to me means I don't understand what's going off. So it could be something. So we'll come to this, just come back, okay? Now go forward slowly. You're doing brilliant. Nice and slow, nice and slow, nice and slow. Okay, keep that torque on, nice and slow, nice and slow, nice and slow. A little bit of air, you can see where it wants to go.
Could I move the scope?
Yeah, you can now. Nice and slow. So when anyone gets what you think is discomfort, I just pause, stop, take it back for a couple of seconds and just give them a bit of time. Okay, now you're coming close to where you want to be for the first one. You can stand up straight, your mother's proud of you. Great stuff. Standing up straight pulls that round. Great. Keep that don't let go of that scope. Right, now draw back, draw back, draw back, draw back. Keep that, do not let go of that torque. You're letting go of it. Clockwise torque. Stop playing with the wheels.
I just want to keep it.
You do, but you were pushing the tip forward. Okay? Now let the anti-clockwise come in. Slowly. Now suck. 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 Good. Taking it back, pause, taking it back, clockwise torque. Now go forward. Now, you don't need to change the torque, my friend. Hold the scope here. Good. Now, look at the folds as they go in that direction. Hold the scope here and let the scope come back. Okay? Now, the scope will now turn for you. Big wheel back. Increase it. Excellent. And up. Now, when you ever come to a bend, Eric, when you come to a bend, he knows what I was going to do to him, is that the scope is here and you want to go up. What you're doing is this. So the scope shortens. What you need to do is go forward, slowly pull back, go forward, slowly pulls back, go forward, and then you can go round.
Okay.
Don't commit to, all right, big wheel back, because as soon as you do, it's here. You're shortened. Okay? So a little bit of big wheel back, a little bit of forward. That's why you see people like myself, Vakar, Saad, we do this.
Yes.
Excellent. Big wheel back, nice and slow. Nice and slow. Now, what's going to help you here? That's it, brilliant. So, where we've got now is a chap who's on his back. Now, and what happens is, if we're trying to get around the splenic flexure, all the bowel is flopped right down. So what will open that up for us is to put him onto... What will open it up for us if we put him...
So yes.
Put him onto his...
No, there is no need, sir. We just it is not inflated. If the colon will come inflate, we can move forward.
What I'm saying to you is, what's going to help you back in your own unit with this guy is if he come onto his back, that will open up the splenic flexure in the majority of cases. Oh, it will. It will. Come onto your back, my friend. All the way onto your back. Over onto your back. Watch. Keep your eye on the lumen. Oh, what's it done? Huh?
Yes.
Yeah, but that's worth me playing ticket, wasn't it? Suck, don't advance. Suck, don't advance. Suck, don't advance. Suck. Now draw back the scope 2 centimetres, 3 centimetres, 4, 5, 6, 7, 8, 9, 10. Do not take that position. I'm looking at your thumb. Advance the scope slowly, steer with the wheels. Advance your 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 scope slowly, steer with the wheels. You took your thumb off that scope?
No.
You did take your thumb off
Just
that scope.
for that's
Jar,
what
doesn't matter you took your thumb off that scope.
No, no. For that's what you
Right, the reason why I don't get you to take your thumb off
to
is
bring
that
my hand back.
it doesn't, you can get this close. We need you to get over that fold, you see.
Yes.
Okay? Now what's causing the resistance? Is it the fact that we've got resistance
Yes.
or lack of gel?
We got resistance into our
So what's it by? Resistance or lack of gel?
I think resistance. Resistance is not there.
Gel.
Gel. Yes.
Gel.
Gel. Yes.
Put some gel on. So, let's take the scope back a fraction. Yeah, now put some gel on. Plenty of gel on the scope. That's great. And now advance the scope. The lumen's down at 7 o'clock. Excellent. Good. Open your stance. So, don't waggle your wheels. You don't need to. Who are you, Zorro?
Okay.
Brilliant. Go on, you're doing right now. So where's the lumen? Come on, Zorro. You can see where it wants to go. Steer back in. Good man. Good. Well done. Go forward. Oh, keep going, Zorro. A little bit of air, my friend. Air. Blow. Go on. Air. Not water. Air.
Yes.
Okay. Bit more. Now draw the scope back. Good. There we go. Keep going. Keep going. Keep going. Turn the buttons this way. Big wheel back slowly. Slowly. There. That's it. Now he's going to want to wash this with you, isn't he? Okay, wash that area, my friend. Wash that area.
He was having very nice vertical splenic flexure. I did not feel any difficulty while crossing these both flexures. Well, normally I do when I do cases over there in Islamabad. When I crossing splenic flexure.
It's the weather.
Not all that. It is my technique. I don't know how to try this.
It's sandy up there. Well, we think so. Is there a fire in there?
Yes.
Is there a fire in there?
Is it okay?
And just have a little look around. So where do you think you are?
I'm in Sikkim.
So did we get round the splenic flexure? Of course we did.
Yes.
Did we get round the hepatic
Yes,
flexure?
we did.
Yeah.
But we did not know to when we crossed both flexures.
Well, I did.
Yes. You are expert for that, so
Ah, no.
we are
So,
learning.
when did we actually get round the splenic flexure? What did we do to get round the splenic flexure?
Well, we turned the patient on
Right.
a position and the splenic flexure
So,
opened.
so what do you think about putting the patient on the back?
Yes, that was very nice.
Okay.
Yeah.
So once we've got a straight scope, putting the patient onto the back
Okay.
will get you straight round.
Okay.
Okay. Okay, my friend, make sure that we get to see the proper landmarks and then we'll be happy.
And also you see the pancreatic opening here.
Yeah.
So not pancreatic opening, sorry, the appendix opening.
Yeah.
Appendix opening.
So,
Maybe right there. But,
yeah.
Here.
I can see it just there.
Yes, this one.
Yeah.
This is open. This one. This is open.
Yeah.
open.
So if you do this, just this here, a little bit of air and water. More air and water, anti-clockwise. Just a little bit of anti-clockwise. More air and water. Now let it come back upright, keeping that going. If it doesn't go in, not too bothered. Okay. Can I just try to get it in once for you, my friend, and then once it's in, we'll be happy.
Yes.
You did brilliant.
Yes.
Okay, so what you've got, you were in. So you've got a smile on your face at last.
Yes. I was relaxed with the 12 o'clock position of the
Okay.
ileocecal opening.
So there we
When
go.
you
I'll
teach
put it
me
at 12 for
yes.
you. So it's at 12 now.
Today in morning when you taught me the 12 o'clock position,
Yeah.
that was very relaxed. And
There
I
you go.
could cross it very well.
So we put it back. So we get it again at 12. You can see it. See it? So it's just right above me here. Right above me.
Yes.
And there
yes.
you go.
We crossed it.
Yeah. Okay. Happy? So you can go into it now yourself.
Yes, you can.
Okay. You can see it?
Yes, I
Okay. Good. Bit of water, bit of air. Take the J off, that's better, and out you come. Well done. Go back in, because you just missed it. Go on, in. Big wheel back slowly. Stop. Now, blow water and air. Big wheel back up a little. That's it, keep it going. Big wheel back. Up, up. That's it. That's brilliant. Let it off, just a touch. Because what you're doing is that you're hitting it, you're doing it, and then you're coming over your shoulder. Wrong direction. Wrong direction. Okay?
This one?
Now you just click back. You've clicked back. Okay? Go forward. That's it there. Big wheel back, slowly. Advance. Air. That's it, you're in now. Okay?
So, if I go forward, should I advance it? Go?
Suck. Just a little suction, not much. That's enough. Now go forward.
Okay.
Now water. Water only. Now go forward. There you go. That's how you enter. Okay?
If I was willing to take biopsy, I can take it from there.
Yes.
From ileocecal.
Yeah.
Is
Happy
it
ma-
normal?
Yes? That's just bubbles.
Is it reverse?
Bubbles.
No,
Bubbles. You ever seen Finding Nemo?
no, I haven't.
You haven't seen Finding Nemo? Nemo is not in there.
It is a bit nodular.
No, that's bubbles.
Okay.
Squirt some water in.
Okay.
Squirt. Now squirt some water in. Squirt water. Yeah, that's better. He's going to give you some water. See the bubbles?
Yes,
Happy now?
yes, happy.
Yeah, Finding Nemo. Bubbles, my bubbles. He doesn't know Finding Nemo. You know Finding Nemo. You've never seen Finding Nemo? Disney film.
in my childhood, not much.
Oh.
I was young.
There. Big wheel back. Good. Excellent. You're just sucking normal mucosa. That's great. Keep coming. That's you. It's a technical term. You rogered it. We'll explain on our own what rogering is.
Walaikum assalam, beta. Walaikum.
He did really well. He did really well.
I like the way he was actually moving the scope and
I tell you,
maintaining it.
yeah,
You know, he's using the
he's
cord.
he's come on, brilliant.
Yeah.
He's actually listened. He started off with the scope round here. I went over and said to Zia, he scopes like me.
I
The
did the first case we did yesterday was with him.
his
In fact,
face
that's
was
the
a
only
picture.
case I did.
Well, his face was a picture when I turned around to him, put him on him. I don't think it'll work, sir. So we had a little bit of a discussion. What happened, my friend?
Yes.
He put him on the back. And what happened to the splenic Fletcher? He said, come and take me. Easy. See, the thing is, an easy colon is one that you say, this is an easy colon. Why can't you say that you made it look easy and take away from you, and now sit back and say, what did I do different today to what I didn't do yesterday, and what I didn't do last week, or what I did
go
do
back
last
in.
week? Go back in.
Go back in, please. Just here. Down. Just wash there.
Bit of water, my friend.
Hmm? What is that little, or is it just
It's a little bit of air, my friend.
put some air so that, yeah, thank you. Put some more air, please. So
Don't
you need to
suck the
become
water.
like a hunter,
Don't suck.
okay? So, okay? That's what I tell people. You need to become like a hunter. When I went first time, maybe it's not first time, but once with somebody, I said, oh, the deer. I said, where the hell in the dark can you see the deer? Because we can see the eyes. And I said, how can you see the eyes? Then I realized it's exactly the same for us when it comes
Now
to pollen.
clear. Now you can suck.
It also tells you how would you suck is what you need to show us.
Yeah?
Yeah, you should, but yeah, good.
Take your finger off the suck. That's brilliant.
Ready?
That's good. And blow.
Right, Paul? I'll do what I...
Do best. Do what you do best. Are we happy?
Yes, tomorrow again, inshallah, I will try to cross again this both further with you as well. While going back to Islamabad, so that I will keep trying on your tips which you will be giving to me.
Well, it depends who you're working with.
No, inshallah,
Well-
my supervisor, he is very nice.
Is he?
Yes, he is very. I think he has worked with you as well, Brigadier Amjad Salama. He has visited. He has, I think, attended your workshop.
Was I nice to him?
आप जानते हो ना?
No, was I nice to him?
Yes, you are nice to everyone. You are nice. You are favorite of everyone.
Not a favourite of my wife after I call her short, fat and hairy.
She also passed the comment I didn't at that time when I interviewed. I think she told me something as well.
My wife is very, very good. She stands up for herself. Okay, my friend, if you want to retrovert, they have to go back in their left. If you retrovert on their back, you will hurt them. So always put them back on the left. So pull it down to about 10 centimetres. Nice and steady.
Dr. Okar told me that first come to the anal verge, then again go upward, then retrovert. So both are my teacher, you and Dr. Okar. So what should I do?
We're slightly different. I tell you what,
Yes.
I'll let you take the choice. I've got no problem. All I'll say to you is there's more than one way of skinning a cat.
Okay.
So Vakar's way works, my way works. You decide what you want to do.
Okay. So I think this 10 centimeter is better.
You do what you've been practicing.
We are practicing this 10 centimeter.
Okay, you do that.
We cross last fall,
Yep.
and then we recovered.
You do what you feel comfortable with.
So,
You're doing what you feel comfortable. No,
Sir,
I
can you hear me?
want him to do it the way he feels
I
comfortable.
don't know if you guys can hear me or
Good. I can
see
hear you.
us. I can't do much about it.
Sir, can you hear me?
Hello?
आवाज आती है?
Hello?
We can't hear you.
Yeah, I can see it.
Covered by, I think,
Can you see
बेटा
that
वहाँ
little
दिखा
bit
रहे
of
हो
an
क्या कर
ulcerated
रहे
area
हो?
on that
आवाज
hemorrhoid?
तो नहीं आ रही है.
that bleeding from the side.
Yeah, that's what I would say.
और फिर वो
Just
फायदा
that
नहीं
little
होगा.
Dr.
hemorrhoid.
Saad Saab.
So, happy?
Yes. So
Can you hear me?
okay or not?
Yes, yes, we can hear you, sir.
No. If you're comfortable with something, just because you do
We
it
hear both
slightly
of you.
different to me, doesn't switch.
Yeah?
Hello.
Yeah.
नजर हमारा आ रहा है नजर भी नहीं आ रहा.
सर आप हमें नजर आ रहे हैं लेकिन
I can't hear
आवाज
them, so I don't know.
डॉक्टर पॉल की आ रही है. उनके मेनली उनके आ रही है ना. अच्छा
मालूम है.
सर ये मेन चीज़ है, एक मिनट.
Stop. Can we have
Sir-
screen, please?
Sir, would you please demonstrate the interdampular?
No screen.
सर साथ नियाज
यार
डॉक्टर
अंदर रखा
साथ
है
नियाज.
निकाल दिया तुमने.
Yeah, what should I say?
Hello, Wakar. Oh, sorry.
Yes, sir, we can hear you.
Oh, you can hear me? Okay, fine. I was waiting. So tried to go in once. Somebody has already done a little cut here, so it's already a manipulated ampulla, and we are in. Okay. So, huh? Wait for a second. अभी तो मैंने I've just gone in. I was waiting. I couldn't hear them. Can you guys hear me?
Yeah, yes, sir.
I don't know if you saw us going in. I couldn't hear you, so I just went in. So it seems like we are in a duct. I'm not sure which duct. It could be pancreas. So we'll wait for the X-ray.
Sir,
Yes.
can we see the floor
It will
view?
take us a minute or so before our X-ray because I think there was something wrong. Sorry?
Can we see the floor view as well?
Yeah, you will once we've got it. I have the fluoro is warming up a little bit. So it's been not been used for 2 days, I think. So it's gone dead. But we are in a duct for sure. As I said, I'm not sure we are in the pancreas, but I get a feeling that we are probably in the CBD. Okay? But this is a collapsed system, so quite often when you have a collapsed system, in my experience, we end up getting into the pancreatic duct much more easily because the bile duct is really, you know, as you could see, there was nothing. Yeah, it's going very easily. But we know that the obstruction is approximately at this side, so I'm not sure. So I would not manipulate any more without the fluoro because there is a chance that I may be in the pancreatic duct no matter how confident I am. So better be safe than sorry. And now we have a problem with the fluoro. If there was no stricture, then it would be easy because I could have gone in deep, and the way the cannulotome moves, it gives us a good idea about whether we are in the pancreas or in the CBD, and also we can see some bile coming up, we can aspirate. In this system where there is complete stricturing, there is not much you can do except use fluoro and see what happens. No, I'm not surprised. So We have a problem with the fluoro. Oh, we've got some bile. Interesting. Can you show this? We got some bile from this thing. So we are not only in the not only the fact that we are in the CBD, but it suggests that there may be a communication. So let's see. If the fluoro works, then great. So for pregnant ladies, when I'm doing ERCP, I've got enough reason now. If I know that they've got a small stone, I do a sphincterotomy. I haven't used the fluoro. I will not use the fluoro. Go like this, put a wire up, put a balloon up, try and do a balloon sweep, a small short balloon, and that's it. If we can avoid fluoro completely, that would be one way. If not, we usually use maybe 1 or 2 spots of fluoro. While I'm waiting for fluoro, you want to ask any questions, please do. Can they hear me?
Yes, sir. Actually, we want to see how you approach the sphincter and how you found it, but the issue was that at that time your voice was not coming.
Oh, you wanted to know how I do that? I thought you could not hear me, so I know I had the patient already ready, so I couldn't wait. I'm sorry. I wanted to wind this up because we need to do one more case, and that's why we were telling you that when we are doing these cases, we are doing them, we try and do them quickly so that if the fluoro wasn't an issue, I think we would have had probably done most of the thing already. It's very frustrating for me because I know that now I'm in the bile duct for sure, and I've gone up. I don't know where we've gone up, but we are deep in the bile duct. क्या हो गया यार? एरर दे रहा है, अब क्या करें? I'm sorry, but there is a problem with our fluoro at the moment. It is giving some error. If we can't do, if there is a problem with the fluoro, is this what is going okay? Yeah. If there's a problem with the fluoro, what I'm going to do is, because they had some difficulty getting in, I'm going to do a sphincterotomy and come out. And then bring her back tomorrow and do it tomorrow once the fluoro is sorted out.
Sir, can we pass a stent?
No. How do we know where the stent is? Is it gone beyond the stricture or not? What I can do is safely here is, if I have aspirated bile, so I'm comfortable we are in the bile duct, I can do a sphincterotomy. Okay, something has happened, great. Okay, now wire. No, this is going in that other space. Now it is possible that the bile was coming because, now let's put some contrast. Yeah. There it's going into that space. And that's communicating with the CBD there. Okay. Now can you see the picture? Can you see fluoro?
Yeah.
Okay, good. यार बहुत ज़्यादा तबाह हुई है, but who knows? Try. It will go with a loop.
Sir.
No. Hello?
So what is that large thing in the mid of the CBD?
No, wait. Let me see, I've come out. Okay, now what I'm going to do is just put it here. Yeah, go on. Yeah, this is how it's going to go. यहाँ से you need to go this way. डालो डालो No, it's looping. There is too much space. So इसको straight करो. What we'll do is otherwise we'll use the balloon. No, it's going. It's a very big space there. It's a very big space there. I'm going to cut this, put a balloon up, and use a balloon. Ready for cut off metal? What happened? That's enough. Balloon. वायर मुझे दूसरा देना कोई. चलो ठीक है. Let's try this again. यार डेल्टा वायर पता नहीं होना चाहिए या नहीं है. आई एम नॉट श्योर. अच्छा ओके जी. Akram, give me a little bit of a blow here. Bow here. Ready? Okay. Okay, now. डालो. देखो जाने से पहले देखो कहाँ जाता है. इस स्पेस से घूम के जाता है नहीं जाता. हाँ जाने दो. जाने दो. नहीं, that's going in the right. नहीं जाएगा.
Sir, we cannot see the endoscope view.
हाँ वो चला जाएगा. तो we'll have to keep trying. रास्ता is actually through this. That's the problem. तो बस देखना डेल्टा वायर या कोई दूसरा वायर है. You're trying to create a loop. We have many which are used. तो आप हमसे पुराना वाला ले लें. क्या? Used वाला ले लें. Give you the loop. We are used to it. हम नए वायर को थोड़ी यूज कर. I thought I wasn't sure what you were doing, डालो. नहीं, no issue. So the problem is this. Pull back करें.
Dr. Saad,
जी.
what you did was you first cannulated the sphincter, then
Yes.
you put in the dye. Then
एक second. Doctor साहब एक second, just let me just sort my things out. I inject a bit of contrast, but Vakar, I don't think the track is direct. I have my doubts. The track is somewhere here, and it has to go like this. Dalo. You see there? You see the track is here and here. Okay, so it's not going to be easy. The problem is that you've got a big opening here. Can you इस पे लगाओ? नहीं ठीक है. कर दो मैग्नीफाइड मैगअप कर दो. साला हीट अप नहीं हो जाए यार. Be careful. Okay, can you see my finger?
no.
Can you see my finger here now?
Yes.
Okay, you see the duct going here. We have communication here, and then you can see the duct going there. Okay, now you know wires can go anywhere, and it's a matter of you keep on trying, and eventually sometimes it might go. So we will try a few times, but the difficulty here is that you've got a big space here. So what happens is the wire goes here in this space and it's not allowing me to find that track. So I have my doubts, but you know, as I said, you can keep trying, but it's sometimes, you know, it's surprising how wires find their way. इसको इधर कर दो. You back on that. Okay. अच्छा, इसके बाद मुझे जो ना मैं दोबारा स्फिंक्टरोटोम ट्राई करूँगा. So that. जाने दो, कोई बात नहीं, इसमें जाने दो, जगह जाना तो उधर से ही होगा. What will happen is you'll form a loop here and then go up. नहीं 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 नहीं, ठीक है, एक मिनट ठहरो, चलो डालो. जाने दो जाने दो जाने दो, या जाने दो जाने दो, या go, you're almost there, yeah, you're almost there, go on. अच्छा, अब मुझे एक काम करो, बलून को नेगेटिव करो. नहीं, मुझे स्लोली नहीं, अब तुम अपने आप को यहाँ लाओगे ना, जब पुल करोगे ये चीज़ यहाँ आएगी, एंड जब ये सीधा आएगा देन यू मे बी एबल टू गेट इट. स्लोली नहीं, एक मिनट ठहरो, वो लूप कम हो रहा है, so you take me up. See if I can go up. नहीं, कम नहीं करो. Stay with, no. Oh yeah, okay. नहीं हो रहा, पुल वापस डालो भाई, बाहर है इसके, बाहर है, that's the problem. हाँ बिल्कुल, पुल बैक ले लो, दोबारा ट्राई करो. या ओके, यस,
मजीद इससे ऊपर
कर रहा हूँ, लेकिन ये अभी टाइट है. See, that's the problem, the space is there. Okay, no problem, right. ट्राई करो, मैं स्फिंक्टरोटोम से डालो, keep on doing, doesn't matter, we're not going to lose anything. Okay, no problem, give me a sphincterotome. Sorry, you were asking me something.
After the sphincterotomy, you introduce the cannula again. Now, could
I
you
used a
explain what
balloon
you-
because it straightens everything. So usually I go with a balloon first and inflate it and then try and put a wire. Sometimes it stretches the thing, in my experience, and you know, you get in a position where you, especially in someone like this, where I think it's very, very difficult. But let's see what happens.
This is interesting because in a situation like this, I would prefer a sphincterotome where I can angle it more.
I use the sphincterotome. जाने दो. ठीक है, मुझे ऊपर जाने दो. नो, पुल बैक करना थोड़ा सा. ये भी भारी है. नो, एक मिनट ठहरो, अब मुझे बो करो यहाँ पे, एंड बो करके वायर दो. ना, पुल बैक. एक मिनट ठहर, वो और कर. अब डाल. जाने दो. Yes, जाने दो. I'm not. Yeah, go on. I don't know whether we are in or we are not. We'll follow it up. Yeah, we'll follow it up. Chalo, relax, please. Go relax. अब जाओ बताया दो. Yeah, we are in the signal. Okay, fine. Stand, please. Yeah. Change. I'll tell you why. It's a 0.25 wire.
25 K.
I prefer a 3.5. 3.5 कर दो इसको. We are up. हाँ? बाहर निकाल. मुझे देना
10
10
9
10
10 10
हाँ, number देंगे तो you have to draw the long
10 10
आधा घंटा के सब जाने
In fact, ideally, if we can have it just about here, it will be ideal. लेकिन it's okay if
doesn't
it's a
matter यार वो अनुकूल की जगह
Yes,
जाके
sir.
train तो
little.
करेगा
हाँ,
yes ready
okay, good. जाने दो. Loop बना लो बस अच्छा हो जाएगा. That's it. Make a loop, yeah. नहीं जा रहा? Okay. I think that's fine. I'm happy. Leave it there. Okay. Removing it. ठीक है. Be careful. You don't want too much pushing and I don't want any looping, okay? Okay, we have to be careful. Slowly out. Okay, great. Well done. Bus. That's it. You already have bile coming. Okay, be careful. Screen 1 minute है. Yeah. And 10.
yes sir 10
Are you all with me? Hello?
Yes, sir, we are with you.
You are?
Yes.
Okay, so we managed to pass the wire. Now we are going to place a stent. I did a small sphincterotomy because I like to do that. And there are people who may say you don't need it, but I personally feel you've got a, I've got a difficult entrance and I don't want to have this headache of wire falling back or something falling back or the stent not going in. Number one. Number two, I feel when it's draining and I do a sphincterotomy and put a stent, it works better than when I just do a stent. But that's anecdotal and I don't have any way to.
I agree with you. I would do exactly the same.
Yeah, I don't. Okay, pull back. Be careful. Be careful. Be careful. No, Akram. Oh shit. Wait. Wire अंदर रखना. This यहाँ पे gap है. We have to go straight. ज़रा भी तुमने यहाँ पे loop दिया ये सारा wire नीचे आ जाएगा. So you have to be very careful. Okay. अब now slowly. इस पे tension रखना wire पे. Pull back. Pull back. No. नहीं रुक जाओ वापस अंदर डालो. Let me take this all out. Wire on the ठीक है. Vakar, let me handle it please. Sorry if you don't mind. Okay, wire अंदर डाला.
yes wire
I want wire in.
yes
नहीं जा रहा और?
नहीं
Pull. Stop. I don't want any tension here. ठीक है. I want straight. अब जब मैं कहूँगा तो you'll pull back. Pull back wire थोड़ा सा नीचे लाओ. That's it. Leave it there. अब थोड़ा सा ऊपर डालो.
yes
बस. That's it. No more.
right
And एक movement में I'll go up and you'll come out. ठीक है. यहाँ देखते रहे. Pull back. That's it. Okay, that is the key thing. Sorry, Vakar. We were getting confused. हाँ, अब now the stent में भी यही problem होगा. Okay, because we have this loop. ठीक है. We have one loop here and we have one loop here. जब वो यहाँ से जाएगा और मुड़ेगा तो this will want to go here. क्या करना है? वायर को रिपोजिशन कर लो. मैं अभी दूसरी पोजीशन कर देता हूँ तुम्हारे लिए. एक मिनट ठहरो. अब कोई मसला नहीं. पुल बैक करो. नो पुल बैक करो. अब डालो. इस वाले में चला जाए. देखो. चलो डालो. I don't like this bulge, है ना? Vakar? This bulge is a little irritating, but anyway, let's see. एक मिनट ठहर यार, मुझे ज़रा comfortable. एक बार ठहरो, मुझे नीचे आए. चलो डालो. तो साला जा ही उसमें रहा है bloody thing. एक मिनट है, थोड़ा सा मैं और पीछे कर रहा हूँ, एक मिनट है, चलो डालो, लूप बनेगा तो जाएगा, नहीं तो नहीं जाएगा। चलो अल्लाह मालिक है, लेट्स ट्राई। ठीक है, सेम थिंग, ठीक है ना। वायर पुल बैक करो, इसको जितना अंदर ले जा सकते ले जाओ। Oh, I've lost the fluoro. Shit. Okay, ठीक है? Right, let's start. Yeah. Right. ये जो चीज़ है ना, ये इसको स्ट्रेट रखना है, तो पुल बैक करना है। जब मेरा स्टेंट उधर आएगा मैं तुम्हें बता दूँ, ठीक है? Okay, this is the difficult thing. अब pull back होगा. I need to straighten एक मिनट है. Okay, this is better. Pull back. Okay, pull back. हाँ ठीक है, बस almost there. Almost there. Okay, pull back.
Yes sir. Pull back.
Yeah, it's going well done. थोड़ा सा pull back दो मुझे.
Yes sir. बिल्कुल.
सिर्फ तुम pull back दोगे ही जाएगा. That's it. Yeah. Well done. It's good. Well done. Well done. Okay. Pull that.
Yes. Pull back.
Parallel back. लंबा हो गया स्टाइल. Contact would be a little longer. Okay, Carol out please. थोड़ा सा और.
Okay sir.
That's fine. That's very good. That's okay. चलो, that will be good enough. I'm happy.
All out.
All out. अभी देखो first class. You won't expect a lot of bile coming out because this is a collapse system. It was already draining and had a stool up. Thank you.
Dr. Saad,
Yeah.
that was excellent. So that shows that even if when you get a cutoff on MRCP, you should always try ERCP.
I think this was a 21-year girl. Waqar se I discussed, and Waqar also felt that it's worth giving it a try. As I said, wires when you're doing initially, they make you feel as if obviously it's difficult. If anybody has played carom or snooker, that's what we did with the wire. There's a difference. Waqar always uses the sphincterotome. I always use sphincterotome, but I had a feeling that it was not making my way. So I wanted to put the balloon first, try and see what the stricture was like, and then I realized that I needed to have something that would push me in a different direction. And one way of doing that is sphincterotome, bowing, using the wall of the bile duct, and literally playing carom or snooker, whichever one you have played in your life.
That was very well demonstrated. There's one observation, Dr.
I'll
Saad.
I'll come and I'll talk to you there.
Okay.
So that was good, yeah. But look at the girl.
इसमें सबसे बड़ा जो टर्न-ऑफ है ना, ब्लॉक है, दूसरा आपका सारा मैप जो है खराब है। हाँ? ये सबसे बड़ा जो टर्न-ऑफ है, that is the block.
And that's the problem is that wire is
इसका भी आप उसको करेंगे, that will make it worse in visibility. तो इसमें मतलब